We're going to start with each of you. We'll go down the line. I'll introduce you. Give us 3 minutes. Hit a couple of highlights. You won't be able to cover it all, but give us a 3-minute talking point that you think the people in the audience need to know right out of the gate here. Joanne, can you give us some of the key points that we need to be aware of from a provider, from a hospital standpoint?
I think what I'd like to do is just start by giving an overview of where we've been in Wisconsin in our healthcare markets. You probably all know that we have a low uninsured rate in our state, especially compared to the rest of the country. We have one of the lowest in the country. So we're starting from an uninsured perspective from a more positive place than other states. We have been nationally recognized as having very high value care, high quality and great access to care in our state. And that's not necessarily like other states. We are actually second in the nation according to a national study. And we were beat out by Minnesota by just a sliver, so we have a little competition there. We have a very competitive insurance market, and unlike other states that may have 60, 70, 80% of the market dominated by one insurer, we don't have that in Wisconsin. We have a lot of local provider-owned plans that are committed to providing patient-centric coordinated care and that provide a lot of choice for all of you as consumers and employers. The ACA includes several provisions. Access to coverage is one, quality improvements is another, and new payment and service delivery models is a third overarching theme. It's access to coverage that's most imminent, as we all know, with the exchanges looming large. And we, as your hospitals, are paying for that access to coverage under the ACA through $2.6 billion in Medicare payment cuts. Access to coverage is a very important issue for us. We know that beginning January 1st, we will have about 90,000 people who are currently enrolled in the Medicaid program will no longer be eligible beginning January 1st. Some of them might work for you. We also know we'll have about 80,000 people who are newly eligible for the Medicaid program, and thousands of others who are looking for new coverage in the exchanges. So a lot of transition with thousands of people kind of wondering what they're going to do and how can they access coverage. We know they will be patients that we will be seeing in our hospitals, and so we have been engaging with our hospitals and working very hard on trying to understand what we can do to help people enroll in coverage, and our hospitals are considering what staffing capabilities they have right now to do that. So we've been doing a lot of work around that. There's still a lot of unknowns. We don't yet know what the premiums, deductibles, and co-payments, well, the insurers probably know that, but the rest of us don't yet know what that's going to look like in the exchange, and we won't know till October 1st when they go live. Will people find coverage affordable, and will they maintain that coverage? We can enroll people in coverage, but will they continue to maintain those monthly premiums when maybe they haven't needed to do that in the past? So maintaining that coverage, not increasing the number of uninsured in the state, and reducing uncompensated care are some of our goals.
Thank you very much. Next we have Mike Durdzinski, Senior Vice President, Johnson Insurance. Mike?
Thanks, Steve. This format kind of reminds me of speed dating for intellectuals. But anyway, there's 4 points of information I want to leave you with very briefly. Number 1, the importance of October 1st as a date. Not only do all employers, and I mean all employers, doesn't matter if you provide health coverage or not, need to provide a notice of the exchange to all of your employees. So regardless of whether you provide benefits or not to your employees, you must provide a notice as of October 1st. And also that's when the exchanges begin operation. And the exchanges really, the vocabulary is starting to change already. They're now called federal marketplaces. And here in Wisconsin, we'll have a new vocabulary that we need to learn. So as it relates to federal marketplaces, we have to think about QIPs. You know, we've had HMOs, PPOs, POS, ACOs, ASOs, now we have QIPs, qualified health plans. And for the federal marketplace here in Wisconsin, we'll have 13 QIPs for the individual marketplace and 9 QIPs for the shop or small employer marketplace. So QIPs is a new part of your vocabulary, qualified health plans. The third point of information has to do with the metallic levels. So when you're buying a health plan, we're now going to think about going shopping for jewelry. So we have platinum, gold, silver, and bronze, and also catastrophic. So eventually they'll give it a name like tin or something, but catastrophic. And the metal levels are tied to another important term called actuarial value. So the actuarial value of a plan indicates what percentage of your in-network medical costs will be covered. So for example, with a platinum plan, 90% of your in-network medical costs will be covered versus a bronze plan where it's 60%. And so part of our new vocabulary, the metallic levels, platinum, gold, silver, bronze, and then catastrophic. And then the last thing I just want to leave you with is looking at what are some of the advantages and disadvantages of buying coverage on the exchange. And I think when we look at the exchanges, there's some obvious advantages and there's some disadvantages. We'll start with the disadvantages. It's a new thing. And as in with any new thing, there's questions about how well it's going to operate. Indicated the number of carriers in a given geographic region. Say, for example, southeastern Wisconsin, there'll be 4 plans in the individual marketplace and 2 in the shop marketplace. So the number of carriers and products may be somewhat limited. They're all fully insured, so if you're looking as a small employer for a self-funded product, you won't find it, at least initially, on the exchange. Some of the advantages is if you are an individual, that's where you go to receive your federal subsidy to help pay for your premium. So if you want to receive a federal subsidy to pay for your premium as an individual, you need to go into the federal marketplace. And then if you're a small employer, under 25 employees, that's where you'll need to go to get your tax credit if you're a small group. And we'll talk about that in more detail later. So that's it, 4 pieces of information.
Thank you, Mike. Next up, we have Kelly Coolidge, Senior Counsel of the Employee Benefits Practice Team at Davison Kelthau Attorneys Law Firm. Kelly?
Sure, thank you. First, I just want to say I'm thrilled to be here this morning. I want to just make clear what perspective I bring to the consideration of the Affordable Care Act. I regularly represent employers who sponsor benefit plans and provide those to their employees. So that includes, of course, group health plans, as well as retirement plans, executive compensation, and every kind of acronym you could imagine in between. One of the things I always like to do is to try to put the Affordable Care Act into a little bit of a larger frame of reference. I know that change is scary. Change is anxiety producing. I think this law in particular has been extremely anxiety producing, not even to mention all of the lively national debate, we'll call it, that's gone on, but because of the length of time between the date it was enacted and that it continues to become implemented. Laws like that just tend, the uncertainty lingers, and we've all experienced that with this one. But I want to also point out that we, as employers have struggled for decades to manage the cost of benefits of insurance, including health insurance that they're providing to their employees. There have been many other different approaches tried. And if we look back historically, in the 80s, we saw the rise of, for example, flexible spending accounts. In the 90s, we saw some, maybe not always so successful, managed care approaches. In the 2000s, I call it, we saw the rise of consumer-driven health plans and new kinds of accounts like health reimbursement accounts, health savings accounts. And then I have no doubt that this decade we're in now will be fondly remembered for introducing healthcare reform. So I'd just like to point out we have gone through changes before, and we will adapt and adjust. COBRA and HIPAA were a little anxiety producing when they came out as well. Now they're mainstream. And what's a little bit different about this law, I have to say, is that I can tell you it's one piece of legislation I'm sure everyone on this panel has spent hours reading. That's not always my experience with laws. I'm usually one of the few in the room that bother, that had the pleasure of reading all the fine print. And
You're the attorney.
so what I would like to emphasize this morning is that there are so many players and people like the people on this panel who can bring expert advice to this specific law. I think what an attorney can bring, instead of just repeating what the law is and how do you count employees and what does the law say, I would like to stress that the Affordable Care Act is only layered on top of all of the already existing law. It doesn't, for the most part, it doesn't make any of that other law go away. And so we have to remember as you're implementing your own programs, to be very mindful of how the ACA impacts compliance with the many other benefits rules that are out there. And we all know it's a highly regulated industry. So wellness plans are impacted. I think my time is almost up, but I think the role of legal counsel in the future is going to focus a lot on that interaction with other laws and also what to do when errors happen and corrections need to be made with the laws.
Thank you, Kelly. Next, we have Terry Lillis. She's a CPA and a shareholder at Schenck SC. Terry, what say you?
What say me? Well, I'm the CPA in the group, and my focus is tax. And lots of provisions in this law are focused on tax. But one of the provisions I want to kind of focus on for a few minutes is the premium assistance credit. Mike mentioned the subsidy. This is the Affordable Care Act, and while they did not necessarily target affordable care in terms of the care being affordable, they want to make insurance affordable. So one of the things is the subsidy that Mike talked about. Individuals that purchase insurance on the exchange may be eligible for a subsidy. And when they purchase insurance on the exchange, they have to meet two requirements in order to get the subsidy. The first one is their household income needs to be between 100 and 400% of that federal poverty level. Now, household income is really the taxpayer, their spouse, and any dependent children that file a return. 400% of the federal poverty level for a family of four is $94,200. So anybody underneath that is eligible for a subsidy, potentially. That is a lot of people in the state of Wisconsin. I venture to guess probably 90% of the people in the state of Wisconsin. It's a lot of your employees. The second requirement when they purchase insurance on the exchange and they meet that federal subsidy or federal poverty level range is that they either have no employer insurance provided to them or it's unaffordable, which means affordability for purpose of a person receiving a subsidy is single coverage only, regardless of what kind of coverage they take, single coverage only. If the employee portion of that premium is more than 9.5% of their household income, they qualify for a subsidy. And so this premium assistance credit, I think, while it might be a compliance thing I have to deal with in 2014, everybody has to understand how this works. Everybody is an individual in this room who has to provide health insurance for themselves and for their family. You may qualify for a premium assistance credit, potentially. You have to understand this. There are implications for this premium assistance credit for large employers, huge implications, and we'll get through that later on in some of the panel discussion. And for small employers, I think this is a planning opportunity for some of you potentially, and it could be a win-win in some cases. So this premium assistance credit, while it's going to be something, a new schedule I have to fill out on a form for some of my clients' returns, I think understanding this is critical to this healthcare reform issue and making decisions. And we'll get into that a little bit more later.
Thank you very much. And last, for opening remarks, Jeff Markquart, Vice President of Regional Sales at Arise Health Plan. Jeff?
Thank you. I just want to say what a privilege it is to be here and be on this panel with this group of experts. And from my perspective, the objective today is to have us collectively have everyone in this room leave a little bit more enlightened than you were this morning. And to caveat that even a little bit, that I don't know that there is such thing as an expert from top to bottom on healthcare reform, because it is such a gigantic topic with so many different components to it that I hope to leave a little more enlightened today myself. But what I've been asked to do right now is to give an overview of, from the insurance carrier's perspective, what healthcare reform means to us. So we're very pleased at Arise Health Plan to be entering the Milwaukee marketplace. We're by no means a new entity. We've been around for about 15 years, but we're brand new to Milwaukee. We've got a new relationship with Aurora, which allowed us to come down here, and in a couple of short weeks, we're going to have a presence on the federally facilitated marketplace. So like everyone else, we're kind of holding on to see how all of that's going to go. We're very excited about it. But one of the things that from the very beginning of the passing of this law, it sort of forced us to and gave us the opportunity to look internally at what things do we do well. How is this new dynamic going to change the healthcare delivery marketplace? And it's going to do that in a very significant way. So we kind of looked in the mirror and had to come to some conclusions, strategic conclusions as to how we're going to survive and thrive in this new environment. So really at the forefront of all of that, the number one conclusion that we made is through all of this and all of the new acronyms and vocabulary that Mike mentioned, we need to stay focused on the fact that our customers are first. We need to kind of shield our customers, employers, employees from a lot of the sort of, we joke often that health insurance is very much like making sausage. You love to go to the Packer game and eat the bratwurst. That's great, but you really don't want to know what goes into making that bratwurst. And healthcare and health insurance is very much like that. You want to be able to appear at the doctor's office, hand them your ID card, get some good care, and have that be covered by your insurance, but you don't necessarily want to know what goes into that. Well, everyone in this room we kind of need to know to some degree what goes into that, but we need to remain customer focused, and we're doing that really with three strategic conclusions that we've made. And the first one is that more than ever, technology is the driving force behind our ability to deliver health insurance, our ability to interface with the federal government, and our ability to deliver what we want to all of our customers. It's never been more important. IT rules the world now, and we just need to be smarter, better, faster about that so that we can continue to do what we need to do. And it's really, really taxing on us and everyone else to try to connect to this mythical federal data hub that exists out there that we're all crossing our fingers is going to work in a couple of weeks. And I believe that it will, but maybe, we'll see. It might not necessarily be perfect on October 1st. The second strategic conclusion that we've made is that, and it's related to the first, is that it'll be more important than ever to be nimble. What we need to be able to do is turn on the dime, because as convinced as I am that the new environment, it looks nothing like the environment that I've spent more than 20 years working in. It's completely different. As we flip the switch on October 1st for January 1st, that's not going to be the end product. This will continue to evolve. There's going to be a lot of learning being done by CMS, by the federal government, by us, by all of you, and this will evolve rapidly and probably significantly. So for us and everyone in this room, I guess I would encourage that nimbleness is going to be a key to being able to survive and thrive in this environment, because it will be not static at all. It'll be continuously evolving. And the third conclusion that we've made, and I think you're going to see that with the insurance products that are, some of our competitors have come to the same conclusion, that strategic provider relationships are more important than ever before. We need to collaborate with provider organizations to optimize some of the kind of finer points in this law, to be able to focus on delivering high quality care and find ways where we and the providers' motives are aligned. And we are definitely working to evolve the relationships that we have with providers to focus with them on population management. That's the key. There's going to be a lot of challenging risk associated with managing people in this new environment. Underwriting goes away, so we need to work with providers to make sure that the quality of care delivered is very high and that we're focusing on much more quality versus quantity. So we're pleased with the provider partnership that we've just put together with Aurora and all of our providers that we've got across the state, and that will be more important than ever.
All right, let's make sausage.